So I'm a radiation oncologist, which means that I use radiation therapy to treat patients with bladder cancer. Radiation therapy is really just high-dose X-rays that I deliver daily to patients. Typically, the patients come into the radiation department, get their treatment, and then go home the same day. It's a non-invasive type of treatment that usually lasts for as little as 1 week or as many as several weeks of daily treatments. Radiation is used in several contexts in bladder cancer, and I just want to go through each of these briefly. It's a component of what Dr. Massanen already referred to as bladder preserving therapy. This is for select patients with muscle-invasive bladder cancer. Radiation can also be used after surgery to prevent the tumor regrowth in the area where the bladder used to be. In addition, for people who have more advanced disease, radiation can be used to alleviate symptoms such as pain or bleeding that are caused by tumor growth, either in the bladder or in other parts of the body, like the bones or the liver. Finally, radiation can be used in very select cases of recurrent non-muscle invasive bladder cancer, usually performed in the context of a clinical trial. So first, I wanted to outline in a bit more detail what bladder preservation therapy, or so-called Trimodality Therapy, consists of. This involves care with all three of the folks that you're hearing from tonight. Patients who are candidates for bladder preservation therapy first undergo a TURBT performed by a urologist like Dr. Massanen. That is to remove the majority of the tumor from the inside of the bladder. Once they're recovered from that procedure, patients then undergo chemotherapy and radiation at the same time. These are daily radiation treatments that usually last 4 to 7 weeks of daily treatments, along with chemotherapy that's often delivered as frequently as once per week. The goal of the chemotherapy and the radiation is to work together to kill all of the cancer cells in the bladder without permanently damaging any of the normal bladder cells or any of the organs around the bladder, like the rectum and the bowel and the bones. When patients complete concurrent chemotherapy and radiation, they then recover from therapy and begin close surveillance, which involves cystoscopies performed by a urologist, as well as imaging studies to ensure that the cancer has not spread outside the bladder. A common question that comes up is which patients are best suited for bladder preservation or trimodality therapy. These are patients who typically are best suited for this type of care include those patients who have relatively smaller tumors that are localized to a single site within the bladder. Bladder tumors have the potential to cause swelling of the kidneys, which is called hydronephrosis. The ideal patients for bladder preservation are those who don't have hydronephrosis, that is, they don't have swelling of their kidneys caused by tumor growth inside the bladder. Ideal candidates also have very little or no carcinoma in situ. This is what Dr. Massanen referred to earlier as cancer cells growing in the urothelial lining of the bladder. Patients who are best suited for bladder preservation also have good baseline urinary function. That is, their bladder works well for them and it's worth preserving. Patients who receive bladder preservation therapy are best served when they can receive radiation in combination with concurrent chemotherapy, because there are several clinical trials that have shown that the addition of chemotherapy improves outcomes who have radiation therapy for bladder cancer. And finally, patients have to be willing to and able to adhere to the close follow-up with surveillance cystoscopies and CT scans that are required after they complete chemotherapy and radiation. And so with that, I'll pass it back to Dr. Massanen to summarize the take-home points from today's webinar.
Okay, great. So I think this is the one of the key slides for the whole webinar today. And there's 3 main points. So the first one is that the diagnosis is based on pathology, and the pathology is important because it guides treatment options. And just sort of as a mini refresher, there can be low or high grade disease. You can have PTA, CIS, T1 to T4. Your specific stage will vary, but that information is in the pathology report. And then imaging, like a CAT scan or an MRI, will tell you if there's lymph nodes that are involved or metastases. The second most important, I think, take-home point is that multidisciplinary teams work together to treat bladder cancer. And I think the best proof of that is that for this webinar, we have a urologist, a medical oncologist, and a radiation oncologist all sitting next to each other giving this talk. And that's a very important take-home point. The third topic or take-home point that I'd like to mention is that you're not alone. So this is a lot of information. We tried to keep this clear, but I'm sure a lot of you will have questions. And so I want to emphasize that there's a lot of resources available for guidance and support. And beyond just providers and the healthcare team, where you're getting your bladder cancer managed, you also have family, friends, caregivers. BCAN is a fantastic resource. There are webinars that cover in more detail a lot of the topics that we talked about today. The website is filled with good information. There's also walks and think tank meetings, and I encourage you to just take an opportunity to check those things out on the website. And of course, there are other patients. The BCAN website is bcan.org. Now, if you're on this webinar, it means you figured out where the website is, but there are a lot of people that have bladder cancer and still don't know about this resource. So I encourage you to spread the word. I want to thank everybody that took time out of their schedules to tune in to this webinar, all the patients, families, and caregivers. I want to specifically thank Rick Bangs for helping with the content on these slides and offering his input and expertise. And also, of course, to BCAN for giving us the chance to share our thoughts on bladder cancer staging and how pathology drives your treatment options.